Welcome everyone to this session, and I would like to acknowledge the traditional owners of Naga, the peoples of the Kulin nations on whose country we gather for this event. We pay our respects to their elders past and present, and to elders of all First Nations communities that are joining us here today. We undertake to walk together with respect with Aboriginal and Torres Strait Islander peoples, communities and organisations in a shared journey to better health. That's what we're doing here. We recognise the ancient and diverse cultures of Australia's Indigenous peoples and strive to consider them in our quest for health equity for all. We would also like to extend our acknowledgement to all First Nations peoples and recognise their unique, crucial and enduring contributions to societies all over the world. And indeed, that's what this session is designed to illustrate, of the importance of networking, of working together, of sharing at a community level, but indeed coming together for a conference like this is sharing what we feel we've learned from our own patches and what we can learn from other people's learning from their patches. And that's what this session is about. I could give you another lecture for 10 minutes. I've got much more to say, but I'm not going to do that. I'd like to hear what other people have to say on this theme of networking, working together, sharing, community engagement. And so on that theme, our first speaker is Natalie Sullivan, and we've got to be regrettably a bit strict on time because we've got a lot of people to talk. So this is not fitting with my personality, but I ought to try to keep to time. And so if anybody goes over time, I might start getting restless. Natalie is Chief Executive Officer of each. I asked somebody what each was, and I was told it was something to do with community health. And so we very much want to hear about each and community health. Thank you.
I'm suddenly feeling nervous. I wasn't, but now I've got the 10-minute monster in front of me. It's a privilege to be here, and I'd like to also pay my respects to the traditional owners of the land, the Wurundjeri people of the Kulin Nation, and also to any Aboriginal and Torres Strait Islander peoples here with us today. As the impacts of climate change and urbanisation become more severe, so will their impact on global health. Hotter temperatures will cause more heat stroke, dehydration, and a higher incidence of cardiovascular, respiratory and cerebrovascular disease. Worsening air quality will result in an increase in allergy triggers, asthma attacks, and other respiratory issues. High density living could result in poorer housing conditions, environmental pollution and degradation, faster spread of disease, and negative impacts on water supply and sanitation. In addition, more frequent severe weather events will disrupt food production and increase population displacement, injuries and death. Doesn't sound very promising, does it? This has not gone forward. There we go. We are a wealthy country, but despite Australia's universal health system enabling comprehensive health cover for most Australians, the health needs of certain demographics remain unmet. Inequities exist across a range of social, economic and cultural measures and cost Australia almost $230 billion a year. The population groups most likely to be faced with health inequity include Aboriginal and Torres Strait Islander peoples, homeless people, those affected by chronic mental illness or disability and their carers, unemployed people or those with insecure, low-paid employment, people living in remote areas and some immigrant groups. I don't know why the slide's not changing. Thank you. Over the past 40 years, the burden of disease in Australia has shifted away from infectious diseases and injury, well suited to an episodic care model, towards chronic conditions requiring attention to prevention activities and coordinated management. Costs in acute and hospital care are escalating to record levels, but outcomes are not improving at the same rate. More people than ever are struggling to access the care they need to stay safe and well in their communities. The burden of chronic disease is continuing to grow rapidly, and hundreds of thousands of people are ending up in hospital each year as a result of not having access to preventative health, locally or locally provided community-based services. On the upside, the Australian health sector is supported by comparative strengths in medical research and education, as well as a thriving industry involved in the development and distribution of health and medical technologies, pharmaceuticals and biotechnology. And while these strengths in biomedical healthcare are admirable, clinical care only accounts for 20% of the factors influencing an individual's length and quality of life. Focusing on the remaining 80%, the role of healthy behaviours, social and economic support, and the physical environment, is critical. I know everyone in this room understands that health is not just the presence or absence of disease or injury. Health is a state of physical, mental and social well-being. And for Aboriginal and Torres Strait Islander people and other communities, this also includes cultural well-being. Australians in good health are better able to lead fulfilling and productive lives, participating fully in their employment and in their community and in their education. The benefits of this are experienced system-wide, with decreased disease burden leading to a reduction in the pressures on our health and aged care systems, and economic benefits demonstrated by an increase in production. In 2017, the Productivity Commission conservatively estimated that the GDP could be increased by $4 billion per year if the health of people in fair or poor health was improved. It's clear that shifting focus from treating one disease at a time to managing the overall health of individuals and populations can assist in building long-term adaptability into the health system and further improve the outcomes for all Australians. So about community health. For 50 years, registered community health services in Victoria have been responding to the needs of Victorian communities, supporting millions of people through the provision of high quality and high impact services. Community health services generally comprise multidisciplinary teams of health and allied professions who provide targeted health promotion, prevention and management services. Our aim is to protect the health and well-being of local populations, particularly people who are at risk of the poorest health and/or have the greatest economic and social needs, while taking pressures off the traditional primary care or GP system and the acute healthcare system, hospitals and ambulances. Registered community health services aggregate and connect multiple funding sources and systems, supporting communities to navigate complex service models, and we make the system more effective and efficient. Working within this model means that community health services combine robust clinical health service delivery alongside a wide range of social services, either delivered directly or through extensive local partnership within our communities to provide integrated wraparound care and support. Let me share with you an example of how our services support communities through natural disaster. In recent years, Victorians have endured difficult times with catastrophic summer bushfires, floods, COVID-19, with all its associated impact of local and regional lockdowns, school closures, unemployment, financial distress, increased family violence. These disruptions and emerging issues have occurred in the context of rapidly changing climate, with higher temperatures, more frequent and extreme weather events, greater risk of bushfires, floods and sea level rises, all which have disproportionate impacts on people living with socio-economic disadvantage. In 2021, in partnership with other community agencies, we developed and implemented a storm recovery program in response to significant storms that were experienced here in Victoria in the Yarra Ranges. Dedicated wellbeing officers worked closely with council and community partners as part of the response, providing psychosocial outreach and counselling to community members. Staff proactively connected with people and offered support, particularly targeting those who are already experiencing significant vulnerability or trauma likely to be exacerbated by the storms. This included families who had lost their homes, had been re-traumatised by floods because they'd previously experienced bushfires, or those experienced significant health, mental health and social vulnerabilities. The climate is changing and becoming increasingly unpredictable, and as a result, disasters of various types are occurring with more frequency. The Community Recovery and Resilience model recognises that engaging in capacity building and preparedness work in between disasters is equally important as engaging in actual recovery work after a disaster. Improving the health and wellbeing of individuals living with a chronic condition or a community recovering from natural disaster cannot be achieved with a hospital bed, a surgical procedure, or a new biomedical technology. Community health has demonstrated time and time again how effective community-based solutions are in addressing the impact of global health issues at a local level. Our vision for a brighter future requires fundamental changes in the health and broader government sectors. We need to redesign the health system and shift from treating patient illness and injury to managing consumer and community health and wellbeing. We need to shift from accepting one-size-fits-all, top-down, government-determined models of service and care to place-based solutions that recognise the unique characteristics of community. We need to move from a fragmented illness system to a holistic and preventative and early intervention approach. And we need to move from extending life to improving the quality of life over a lifetime. Let the hospital system look after illness and injury, and empower and invest in communities to live happy, healthy lives through place-based prevention and early intervention approaches designed by communities and delivered in communities. While I proudly speak to you today as the CEO of each, I would like to acknowledge my colleagues across the other 23 registered community health agencies across Victoria who share our vision for a true health system, not an illness system, and who work tirelessly to support the health and wellbeing of all Victorians. Thank you.
I hope I didn't scare you into keeping to time. But that means we do have time for questions. Questions or comments on what you heard? You presented us, started off with the national picture, and then you went down to the community level. Do you see that as the way to address the national picture? There's a roving mic there.
Yes, I absolutely do. And interestingly, community health was established across Australia by Gough Whitlam 50 years ago. Every other state and territory in Australia has dissolved that model. And interestingly now, with the review of the Medicare service, there's a shift and an eye now to looking back at that multidisciplinary community-based service. So as I speak, we have the Federal Minister for Health and Ageing visiting one of our sites. So half of my team have headed back to the office. So he's obviously interested in what does this model look like in other states, and is it time to reinstate an investment in community-based health and wellbeing.
And one of the questions we've been asking is to what extent health services can be addressing social determinants of health. And you're implying that indeed in your model they can, is that right?
I'd like to see a shift from money going always to hospital services. I think the challenge with that is hospitals are very focused on surgical wait lists, ambulance ramping, all the other challenges of expensive equipment, managing throughput and demand. How can they possibly have time to turn their mind to stopping people from getting there in the first place? So I am a strong advocate for investing in organisations like ours who are connected to community, and it can actually work to stop people getting in hospital in the first place. We wait until people are so sick and then we throw hundreds of thousands of dollars at them to make them better. If we just invested more in that preventative and early intervention work that is based in community and not rely on people presenting to an emergency department because they can't afford to get to a GP, then the system is never ever going to get better.
Yeah. Could you take the mic?
Thank you so much for your presentation. I think what's really quite extraordinary here is, and my question is around, how does this work as a system, all of these community health organisations coming together to enable a community-wide ecosystem of care that reflects, I guess, the priorities of a distributed care network, which is what we're hearing from the big hospitals. They don't want necessarily the big box anymore, but they want to recognise that there is care happening in the community. And when I see all those logos, I'm like, well, that's extraordinary as an ecosystem. How do you work across that?
There's a few ways we work across it. So as a group of registered community health agencies, we come together under an alliance called Community Health First. And that's a very specific name because that's where we think people should think about going first with their healthcare needs, but it's also where we think government should look to invest first. So Community Health First works as an alliance across these agencies. It's chaired by one of the CEOs of Access, which is the very top left-hand corner, and I'm the deputy chair of that group. So we are working to lobby and advocate for our platform. But at a local level, we work with whichever health service happens to be in our area. And not just the health service, but GPs and other local community service providers. So whether that's council, mental health specialists, all sorts of things. But we deliver a range of programs ourselves, and where we don't deliver, we partner to deliver. So, yeah.
Other questions or comments? Thank you very much. The next presentation, I'm really interested to hear, well, I'm interested to hear all of them, but the two people who are going to present it, one is in the WHO, head of tools and something development. Her title is about that, that's most of the 10 minutes, product design and impact unit. And Leah's been involved very much in evaluating tools of various forms around the world. So Kidist Bartolomeos from WHO Geneva and Leah from Monash are going to do this together and looking at how you implement WHO guidelines. Is that right? Thank you.
Okay. The title of the talk, at least evaluating the design toolkit for WHO guideline developers, but I just would like to start first just thanking the meeting organizers also for the opportunity to participate in this important panel talking. We focus on one product and a system central to WHO's normative role. That's about development of guidelines and other normative products. And this is a starting point of mostly for member state decision-making process. Often, mostly, when I talk about, even at Geneva, when I speak about improving guideline design, development, or implementation and their delivery for impact, the question that I often get asked is, exactly what do you mean by impact? And for me, it's just the fact that that question gets asked is a validation of that importance of this work, what we're trying to do. This work area, just to situate, started after the new Director General take office, and there was this transformation agenda, the focus on country impact, and knowing that and then this new unit got established in the department that's called Quality Assurance on Norms and Standards, which I'll say a little bit what that means. And this new unit established to be focusing on impact, and then knowing the limited resources we have, we had to prioritize what we're going to do, which was mostly in looking at the co-design of these products. This is just a segue to my session, which I'll be brief. And just in this conference, just again to situate, we heard from many esteemed presenters what change each initiative, program, research, policy is expected to deliver, and what impact means for communities, for practitioners, policymakers. So as we talk today, at least I want to just ask you to consider the impact metrics you yourself are working with for your project initiatives as it relates to our presentation. At least that would help us to hear from you. And what we're trying to achieve with this work, and we're presenting this today with this collaborative work we're doing with Monash School of Art, Design, and then the WHO Science Division, which is the Quality Assurance and Norms and Standard Department, and this product design impact, is to facilitate within WHO for all the technical experts, but not only within WHO, all those other professionals that we engage with in guideline development, to start this shared journey to contribute this impact, the transformation agenda of impact culture, and focusing on this specific about guidelines. So if I may, how do you go next?
Maybe that
this one.
Oh no, forward. Oh,
Thank you. Okay.
maybe.
Yes. This is role of global normative products and guidelines informing local action. This is just the starting to. So we already know there are things that clinical guidelines, or whether we call them normative products or guidelines, these are tools for improving healthcare and improving health, social, economic outcomes, depending what we're focusing on. And WHO develops these guidelines for its member states. And for those who are involved in guideline development, you know that consideration for implementation is always, it's supposed to be considered as part of the guideline development process. Not explicit, but somehow it's been considered. But knowing the variety and the heterogeneity of the member states, the variety of countries, multiple political, economic, cultural, religious systems that exist in developing, it's a really tremendous challenge to say that there is these guidelines out there that fits for everybody and to be implemented in different countries. It's a tremendous challenge, acknowledging that these developments are considered these in their development. And adoption as it is, or adaptation to national level is an important issue, and it's a priority for WHO at the moment. And what we're starting to see is the leadership and capacity in these to do this in a systematic way for adoption is a priority for WHO. And one thing that I personally think is the most important one out of this transformation is this is not just for member states. For the first time, there is this collective accountability. We all should be looking to make impact. It's not WHO develops, countries implement, donors give money, or private sector. Everybody should be accountable for the delivery, for the impact, and effective collective accountability for delivering on this impact. Quickly, normative products, guidelines, what I say, this is really important for people to understand, because some people who work in guideline development, they know that. We have these guidelines which follow a very structured normative quality assurance process managed by the Guideline Review Committee, a very structured. But until, again, through this transformation, there are all these other products. We call them policies, handbooks, manuals, frameworks, whatever you say. Those ones didn't have equally rigorous, transparent quality assurance process. So these are the two different types of products. Even when doing guidelines, you've seen these probably during the COVID pandemic. We have the standard guidelines and those rapid advice guidelines or emergency interim type of guidelines. And the difference is the time frame, the validity of those guidelines being out there, and the time frame and how they're used. And most of the time, they may be adapted to standard guidelines depending on what the topics are. I'm moving. So as we started, we needed to also prioritize. We didn't have resources, and some of the barriers for challenges for implementation and use. This is the first scoping review and some consultations we've done with our countries. It's not moving. Is that two types? I won't get into the details of this. This first slide tells you there are three types of challenges, if I have to put them in a bucket. One, actually the way we produce, put them out there, package them, and communicate. And then these are just some examples of things that were said during the consultation or stuff that came out. Some of these challenges, some of them being very technically, beyond the comprehensive, it needs another guideline to translate the guideline and then another training to implement. Lack of consensus and type of things that in some, if you're having an HIV guideline and TB guideline, sometimes what is said in one with the others is sometimes difficult to align, inadequate implementation plans, and sometimes even conflicting timelines for guidelines. Before they implement one, there would be another one, and countries don't have the capacity. So this is around the way we package, we communicate, how we do them, and no feedback loop. We don't have a way of getting the feedback from countries to actually inform. This is, for discussion purposes, more for insights. They might be examples. We've heard all kind of I was in a session this morning on critical care and emergency care. There are things that work. But in general, this is the challenge we're trying to address. The other is around system-level challenges. Again, this is in a published paper from a scoping review we've done with Ottawa University, Brewer Institute, around system-level challenges around governance, capacity, these enabling inadequate infrastructure, resources, and data and evidence, some of these things that we're trying to address. And finally, design-related challenges, especially when we started putting guidelines into, into these technology or digital health solutions. The way the implementation is done from WHO goes to Ministry of Health and then to technology partners and then goes to health workforce. But in different times, unless we streamline how we do this and how updates are communicated to these technological, there are many challenges that already exist, and this will affect the trust and the fidelity of some of these recommendations. If something is updated, how do you communicate to a technology partner that these things are, especially some of the metrics change, thresholds change, some of those things. So this is another challenge, design-related challenge we want to. Finally, we said, there are opportunities to optimize for impact. Design gives us an opportunity at planning stage. This is the pathway, green-lighted, then produced, and then we hope. We spend a lot of time in these stages, but once they're out, we really don't know much about them. But there are other disciplines that have tools and resources, and this is the collaborative work that we're doing with Leah, and I'll move it to you. Thank you so much.
Can I get 4 minutes grace? I'll be really fast, and we can take questions after lunch. Okay, thank you so much, Kidist. That was amazing. I felt like I was your minder here, standing behind you. So just very quickly, we've been working with the WHO. We've got an incredible team, Monash, EdHec, many of whom are here today, looking at co-designing principles and tools to improve usability and impact of WHO guidelines. How do we engage the participation of those who create and use guidelines to improve usability and impact? And a conversation that we had a couple of years ago, at the beginning of this work, one of our collaborators said to me, basically guidelines are written by very well-meaning scientists in Norway, and they're used by a nurse on a moped in Zambia, and there is a disjunct there. Okay. And I think some of the things that we've heard about in the last couple of days, trust, engagement, co-creation, co-design, knowledge exchange, are incredibly lofty and wonderful. But what are the mechanics of establishing trust, engagement, co-creation, co-design, etc.? And I think a little bit, I'm not sure if anyone else has got a teenager who likes to watch Drive to Survive on Netflix, Formula One. But I think, say Max Verstappen might want to go at 300 plus kilometres an hour, but unless he's got a team of 300, 400 engineers, he's not actually going to do that. And so there's actually mechanics, mechanisms, methods, and tools for doing this kind of work. And so the work that we've been doing over the last couple of years, and it's like our heart work, it's the work that we love to do and that we want to continue progressing, is around bringing together the lived experience of those who develop guidelines and those who use them. And what are the tools and mechanisms that are needed to support that over time? And this is not just about co-designing with end users, ministries of health, health workers, end users, but it's also about developing an implementation mindset. And with those co-design mindsets and that implementation mindset, we start to think about dissemination, usability, uptake, implementation, etc., as opposed to just pushing something out and hoping that it lands. So with the team at Monash, EdHec and WHO, we've been developing design principles. So 5 principles fit nicely on one hand to improve usability and impact, and then developing a toolkit of resources to support people who write guidelines. And that work needs to be done in consultation, continual consultation, and we're very committed to the idea of iterative co-design processes. We call this sequence co-design, multiple stages to engage with communities, to get feedback to them, and to keep that process going. And so since 2022, we've engaged, I've lost track of the number of countries that we've worked with and the participants, but the first workshop was around improving understanding lived experience of people who try to implement guidelines in country, and we used a whole series of co-created personas of people that are trying to implement a guideline in a Tanzanian context. Brought together people across 8 countries to understand those barriers and challenges, but also the enablers. What are the motivations that we have in using these guidelines? We then tested these principles. We developed about 7 principles, and then we brought people together from across another sort of 6 countries to test and evaluate those principles and to see if they were actually supporting people who wrote guidelines, from editors through to focal points that were trying to do the work of writing guidelines. Then we developed a whole series of tools that supported people and supported the writers and creators of WHO guidelines in order to improve usability and impact. And these principles, they're not rocket science, but actually if you implement them and rubber hits the road, they can actually improve things. So design with empathy by understanding people and their context. Design for living, and then there's some incredible expertise in living guidelines here in the room with Sally and Tari. What does it mean to design for a living evidence ecosystem? We think about data differently, we think of updating differently. Design for accessibility, design for clarity, irrespective of cognitive overload, and design for translation to multiple languages. So there are our 5 principles, and we've enacted those through a whole series of tools. And I suppose just very finally, this idea of, the question might be, how do we actually engage people when the rubber hits the road? Sorry to use the Formula 1 terminology again, but how do we actually engage people in a global health context across many, many, many countries? And one of the things that we're working on now, building on all of our knowledge from developing the WHO design principles, is the global consultation for hand hygiene in community settings. And essentially, WHO, UNICEF, WaterAid are developing a new guideline for hand hygiene in community settings. And they really want to know what are the system-level barriers, what are the system-level actors, what are the priority actions across all of the countries. And so last week we trained up 60 facilitators in 10 countries, Bangladesh, Benin, Philippines, Serbia, Zambia, etc., who will go and run co-design consultations with up to 400 to 500 people across those countries. And then it's about bringing all of that data together to understand what is the lived experience, what are the barriers, how are people going to navigate those barriers. And I think, we're not perfect at it, but we're learning and we're trying to build these mechanisms, particularly into implementation pathways. So it's a really exciting piece of work, and we're really happy to share with you today. And this is just a shout out to our amazing team. Thanks.
Thank you so much. Questions, comments? It seems my role to kick it off. My question was two kinds of questions, but they're linked. One is, you've identified barriers, and what I wanted to know, my 2 questions were, one, different barriers for different types of guidelines. I mean, you finished with hand washing, it could be goodness knows what. And secondly, quantitatively, do you have any estimates for different contexts of which are quantitatively the most important barriers, and when the guidelines work and when they don't work? Could you, the microphone?
Thank you. There is a fixed mic here as well. And you talk that one. All right, so this is a collaboration. I might just talk for it. So the first question, the second question, the data question, Kidist was going to speak to. The first question, the barriers, different barriers for different guidelines. Yes. but some universal barriers that we're hearing. And those universal barriers are around workload, time, accessibility, download speeds. Don't send me a guideline that's 200 pages long and that's written in 10-point font if I don't have good internet and I can't download it. And so last year we were talking to some Ministry of Health colleagues from Uganda, and they said, these guidelines are fabulous. They get launched at a party and all the officials take the guideline home and put it on their bookshelf. And that's really lovely for their bookshelf. That's a lovely guideline. But the guideline's it's not where it needs to be used. It's not in the clinic or in the public health setting. And so there are some universal barriers to guideline uptake and use, and Kidist is an expert in that space.
Yeah, and the question on qualitatively, we don't have the data, but what I can say is, I worked in the surveillance and the mortality surveillance and all that stuff. What I've seen is the diseases with the biggest burden are the ones, that's what we use to justify, to get them in the resolution, we get them the money, but the areas that I know that I worked in 23 years ago, the numbers are still the same. The risk factors increased. I can talk about road traffic, for example. When I started 23 years ago working on that, we had less paved roads. We didn't have this many. Now we go to Africa, the roads have expanded, the risk factor exposure has expanded, but the guidelines getting better and better. New things are coming in. Now we're even moving to electric vehicles and all that. But what was it killing people? Pedestrians, right? At that time. So absolutely, we're trying to get there. This is more of a culture change in WHO to have this impact culture. We have accountability. WHO from HQ is not just to produce and put out and then say, oh, Minister of Health, that's your response. And I'll move on to the next one because the evidence moved and things. So absolutely, we need to get there, but at least we're using this qualitative data and things to show that we need to do the things we do. But absolutely, eventually we need to prioritize them if we're going to be asking for investments and where to invest. The health system stuff, this is from the qualitative stuff that we have. But a very good question. Thank you.
Thank you very much. It's a very, very important presentation. I'm a medical doctor from Bangladesh and doing PhD in Australia at the moment. So from my experience from Bangladesh, I can say like my friends, my contemporaries, my other colleagues, doctor colleagues, they love to attend, co-design workshops. They love the food provided by WHO or other, counterparts, like when they are part of the guideline development training. But the main problem happens when they return to their workstations. They don't even bother to open the guideline, at least for once. And I can tell that from my own experience as well. So I'm curious to understand your take on this, because we have a lot of guidelines, SOPs, and culturally, linguistically adapted guidelines. But what about the real pathway to impact? How we can increase the usability of those guidelines? And I'm also thinking about the quality evaluation and monitoring mechanism. If policy have a role to play. Thank you.
So I'm going to test your memory because I'm going to take two more questions. And then ask, I'm going to take two more questions and then ask you to come back. No, there was someone at the back. I saw her first, but...
All right, I'll stand out here and make my way towards the back so you can ask your question next. Rebecca Smith from Medicines Development for Global Health. We have a US FDA-approved medicine for a neglected tropical disease called river blindness or onchocerciasis, and we're currently working with our technical partners to have moxidectin added to WHO guidelines. Can we reach out to your unit, Kidist, for some guidance support in this process, or is there some internal resources at WHO that we can engage with on this journey?
And at the back.
Thank you very much for your presentation. I'm doing some work on implementation guidelines as well, and there's obviously a lot of academic work done around why aren't things implemented, but I'm really interested to see this intersectoral collaboration, I guess, with you, Leah, with the design hat on, and I guess I'm particularly interested to know what sort of difference in perspectives and other skills are you bringing to change the way the guidelines are implemented?
So would you like to comment?
I'll do the easy one first. The one you said we want to collaborate, happy to facilitate. I'm sure there is something. Money may not be the one, but yes, definitely there are processes but opportunities for us to also do new things. Then we're always looking for collaboration, see what we can facilitate. And then I can respond also. Absolutely, that's what we hear. And that's what we hear when we go to countries. And this is the message we're trying to do at the headquarters, trying to say there are fancy guidelines in countries. One WHO representative used to say it could be a doorstop, and some of them, they come. I'm not a post office where you send it to me and I sent it. You have to listen to what we're doing. But it's really an opportunity. For me, I'm looking to my colleagues with the whole living guideline, new wave with technology. We have an opportunity to get, and we heard it throughout this conference, we need to understand the needs and what they want. Sometimes they say, that's not the guideline I want, and my data says, I have this other, can I have a guideline for that? So it's really, we see this as an opportunity, and I want to encourage, and we'll share. Really, it's a moment, for me, it's a momentum that we want to push and want to use, especially with the living guideline work. And finally, there was one additional question. Sort of design approaches. Yeah.
Thanks. All right. Excellent questions, and I'll try and. So you're working on an implementation guide, yeah. Guideline implementation guide, yeah. And the question.
Country level implementation, how we support, right, towards implementation of these. It's this hierarchy, just the change now. Because it used to be HQ develops, regions kind of adapt for the regions, and then it goes to countries, and then it's up to the ministries of health, and then we moved on by the time we get to the region. But absolutely, I think this, what I said about quality assurance of even the implementation guidelines is starting, meaning can we also consider what are we saying about implementation? Do we have all the answers? So that method, that process, is one way we're trying to address it, but implementation, yeah, that's a challenging one.
Just very quickly to that idea of designing with intent for implementation, adaptation, adoption. It's again that mindset shift, and I think some of the work that the Living Guidelines group here are doing, and the work that we're doing with WHO is like, how do we engage end user communities to understand how things actually will be worked and what format is of use in that context. And that's the principle one, designing with empathy for people and their context, their challenges and enablers, so that things actually don't get used as doorstops. Yeah. Or one thing that we heard about the HIV guideline was that people were using the summary of the summary. So 267 pages are not used. There's half a page that is used. So what format might that need to be in, so that we can kind of activate and enable people to get the information they need at the time they need it to do the work they need to do. Yeah. Thank you.
So thank you very much. Next, we move to northeast Thailand, Watcher in Lolome. And I didn't know, but the area in which she works has the highest rate of cholangiocarcinoma in the world, which they have associated with liver fluke infestation. So we're going to hear about multi-sector strategies to confront NTDs in endemic areas.
Thank you so much for the inviting, and I would say that I'm super exciting, and I will do my best to summarize and deliver what we have done for over 10 years within 10 minutes. Okay, so I'm going to talking about the infectious disease, the liver fluke infection that caused the bile duct cancer or cholangiocarcinoma. Oh, sorry. Is this move well? Okay. So this would be the outline of my talks. We've talked a bit on the how important of the problem and what we are doing so far back to Thailand, and also what would be the next challenge. That's why bring me to be here in the World Summit. Okay, so So the story begins with these tiny creatures, the liver flukes. So in our areas, the name is Opisthochis viverrinis. And then the people in our areas acquire infections by eating this kind of, scaly freshwater fish that contain the infective stage of the flukes. This is, the tiny ones. And basically, in the sub-Mekong region country, including Thailand, Cambodia, Laos, and Vietnam, as is estimated 12.4 million people getting infections, which is, I'm pretty sure that is, under number. I think it's more than this. And also based on the evidence both in epidemiological study and also the experimental study, the fluke infections, the chronic ones, is related to the cholangiocarcinoma or bile duct cancer development. And also in Thailand, as mentioned by the MC, we are sitting on the place that have highest incidence of cholangiocarcinoma in the world. And if you look at this map, for all over the world, it's less than 5 per 100,000. But in Thailand, especially my place, in the northeastern part, we have 85 per 100,000. And then as approximately 20,000 new cases a year have been diagnosed. And then you can see this is the cancer tissue, and then you can see, the tiny, creatures is, linings sitting in the cancer tissue. And even we have bad luck, the fish that we eat is contain, disease, the flukes. But the lucky thing is this liver flukes and also cholangiocarcinoma is preventable and also is curable. So in this case, I would like to address this, this great man, our ex-leader, Professor Nalong Pantikau. He is the HPP surgeon who, dedicates all of his life to combating this disease. And then he do believe that if we work together to prevent and screen a high-risk group for early diagnosis and treatment, we can, help people with this disease. So we are working back in Thailand as the cholangiocarcinoma research institute. We have the mission to bring the knowledge and innovation that we have from the research to combat the problem for the people. So this is our mission. That's why we come here to seek for the opportunity to work. And then, so this is our operating structure. So actually we have three main, parts together. The first one is the research institute, which play a role mainly on seeking for knowledge and also develop the innovations. And also we have the cholangiocarcinoma excellence center that they play a role mostly on treatments and training for the public health staff and also the medical. And also nowadays we serve as the hub of knowledge that we play mainly on trainings and technology transfer. So this is our component. And also we work together with the private section called the Cholangiocarcinoma Foundation of Thailand. So in this case, we started from the research base, and then after we get knowledge, after we get innovations, we try to transfer this knowledge and innovation for the problem solving. So in this case, over 10 years ago, we started the program called Cholangiocarcinoma Screening and Care Program, or CASCAP, which is the comprehensive and holistic approach for problem solving. So what the CASCAP is doing, I would say that one problem, but we need many solutions and then many multifacets of approach, because liver flukes and cholangiocarcinoma is not just a health problem. It's related to behavior, because people eating raw fish, right, and then they get infections, and then after that it's involved also the environment, because if you look at the very complicated life cycle of the flukes, it's involved the snail, the fish, and also the water sources. So in this case, it's also environmental problem and also the health system also. So the program we try to do things, in holistic approach, ranking from the primary prevention. We do the food safety, the fluke-free fish. We do the, treatment, screening and treatment in human, in cat and dog, which is also the host of the fluke as well. We do the sanitary system management. We do the education to prevent people from getting infections. And we do screening for the risk people for cancer by using the ultrasound and then send them to get the treatment system. And also we do, the policy research to see the opportunity in terms of policy to solve the problem. And we do the social study as well to answer why people do not stop eating raw fish. Because they know that, right? It's a dangerous, but they still keep eating. And also, so during the time of work, we have, some of the tool or innovation to deal with the problem. The first thing is we have the cohort system. This is I would say this is the biggest database for people at risk and also the cancer patient. So we use this to register people. And also we have the AI-8 ultrasound screening system to help for the early stage of cancer. And also, this is a big thing that happened because for the fluke infection, in the previous time they do feces examination, right? Which is quite tough, and then you can imagine 12 million people by feces examination, that would be not possible. So in this case, based on our work, we can develop the urine-based, the kit for detecting the OV infection by using the urine, and then after 5 minutes of dropping the urine, you can see, who is positive, who is negative. And then I think this would be the new tool to combat with the disease. And also we develop the school curriculum because we do believe, as you guys believe, prevention is better than treatment, right? So that's why we lay our hope on our future, the young. And then this is a big of work. So we work, with the many sector, including the national level, at least 4 ministers: Ministry of Health, Ministry of Agriculture, Ministry of Education, Ministry of Interior, and also the other sector, and also private sector as well. And then we have also the international collaborations, which play mainly, work together for a long time. And this is, the picture of activity that I mentioned, ranking from, the school activity for prevention in the young, and we do screening for the fluke, we do screening for the cancer using ultrasound, and we do treatment for the patient, and we do also trainings, ranking from the very complicated step like the HBP surgeon, the nurse, and also the radiologist, the general practitioner to do the ultrasound screening. We train also the school teacher to use the curriculum, and also the students. And also we train even the community leader, and also the normal people. So this is various types of the course that we provide. And also, after 10 years of work, this is the result. In 2016, we success to don't want to say force, put the government to announce the 10-year policy for combating cholangiocarcinoma, because we know that if there is no policy, that would be hard, right? And then up to now, I think more than millions of the people have been screened for the fluke. 800,000 has been screened for cholangiocarcinoma, and also 25,000 has been treated under our program. And also we can bring down the number of fluke infections, I would say in very specific target area, to down to be like 7.7% now, but we aim for less than 1%, which is quite tough to go. And also we can change the ratio of patients from the very advanced one to be very early stage one by the screening program, and then we can bring up the 5-year survival of the patient, because as you know that if early diagnosis, that would be easier for cure. And then we running project in Thai, and I think we get success, and then that's why we try to adopt this program to be worked in Laos as well. While I'm talking, my team is now in Suvarnakhet, Laos, doing the fluke and cancer screening nowadays. And then, so we started since 2019 in Laos, and then, this is the aim. Like, we try to develop the human resources, screening by the cancer and OV as well. And then most importantly, the raising awareness for the people. This is what we do in Laos. And this is some of the activity that we do in Laos. This is screening. This is also we train SVP surgeon from Laos team to make them keen in CCA treatment. And also we do treatment, we do school trainings in Laos people as well. What should be the challenge? Okay, what I'm talking, it's research based. It's just very specific area. So we would like to expand it as the nationwide implementations that would be help people. And also, we would like to bring this program as a regional program because, as I mentioned, we face the same problem, at least 12 million people in sub-Mekong region area. So this is what we would like to do and why we come here. Thank you so much. Thank you.
Thank you. Well, the challenge of presenting 10 years' work in 10 minutes, you rose to admirably. I have a question. I've got a really annoying friend who's an economist. That's sort of redundant to add that he's annoying and an economist. And he's really annoying. He keeps asking me annoying questions. So I say, we've got to reduce poverty in order to prevent crime. And he says, what if it's cheaper to install cameras? Shouldn't we just install cameras rather than reducing poverty? If that prevented crime, that's cheaper and more cost effective. So my question to you is, which is the better strategy? Prevention with healthy diet or screening and treatment? Is one more cost effective than the other? How would you evaluate?
I would say that these questions hurt me a lot. Because I would say that we have started with the screening program because we have the history of combating liver fluke for a long time. But actually, as you might know, that the liver fluke is totally different from the COVID. When you get infections, it took like 20 years until you get cancer. So people, at the first time, we attacked at the flukes by campaigning like do not eating raw fish, things like that back to Thailand. But it doesn't work well because people just love it. They know, but they just love it. So that's why 10 years ago, Professor Nalong started with the cancer screenings because we learned that if people find out that they have some abnormal in their fever or even they have cancer, that make them too scared, and then they might change their behavior. And then after that, we prove that, okay, I think pretty similar to the other cancer. If you do screening, you will get early case and then you will get good treatment result, right? So we try to convince the government to do the screening as you mentioned, and then we face this, I will say that the prevention is better in terms of, easier to handle or even the investment that we need to put. But the prevention would be appropriate from some other people, for example, the young or the one who haven't get infection, things like that. But for the people who are at risk, you need to provide them the screening program. You cannot leave them behind. So this is my answer.
So if you like sashimi, you have to be part of a screening program. It's an easy choice. Thank you very much. We move on. Somewhat unusually for a global health conference. Our next speaker is head of counselling at a theological seminary, which is really exciting. The Reverend Dr. Ellen Jamir is, there she is. And something that's really important and certainly close to my concerns of intergenerational trauma and in the Naga repatriation process.
Thank you, Chairperson, Dr. Michael. I wish to acknowledge the people of the beautiful Kulin nations on whose land we are gathered today. I pay my respects to the elders, past and present. And I also want to express my deep gratitude to my dear mentors and friends, Professor Kath Chamberlain, who's here, and Professor Marsha Langton. Thank you so much for enabling this to happen, for me to be here today. Yes, this is pretty unusual. I come from Nagaland, and I'd like to show you. Okay, I just go this way. Yeah. That's the map of my homeland. The repatriation of the ancestral Naga human remains is an initiative taken by different communities around the world. And just in recent years, after 2020 to be precise, the Nagas, my people, we are joining a global conversation. The Recover, Restore, and Decolonize, I'll be referring to as RAD team, under the Forum for Naga Reconciliation, FNR, was formed in 2021 to facilitate the repatriation of Naga ancestral human remains currently housed in Pitt Rivers Museum at Oxford University in the United Kingdom. Why intergenerational trauma? And I'll give you the context here. So the Naga people are a transnational indigenous people. My homeland is situated in the northeastern part of India and northwestern part of Myanmar. Naga homeland is divided across 4 different states in India, in Nagaland, Assam, Manipur, Arunachal Pradesh, and our neighboring country of Myanmar. Therefore, the boundaries that exist today are arbitrary. The international boundary marking India and Myanmar runs right through the village, one of our villages, and actually it runs across the Chief Ang's house. Yeah, I'm not kidding. You can come and visit. Like many countries with a history of colonization around the world, India was under the rule of the British for more than a century. India gained independence on August 15, 1947. Seeking the right to self-determination, the Naga people also declared on August 14, 1947, a day before its independence. However, India failed to recognize our aspirations, and our geopolitical aspirations spans over 7 decades now. Thus, the Naga story is one that is marred by bloodshed and unrest. Due to the prolonged nature of the conflict, the movement has split into different formations with vicious circle of violence among the various political groups. So this is the blue in the middle, that's our Naga nation. That's the boundary that we see now, the states, if you look at the map of India. However, the lines, the blue lines, those are Naga areas. Yeah, a few pictures of my people. We look like this. In our traditional attire, these are my students at OTS. We took this picture just last week. Okay, so this is our public engagement, part of what we do. So the RAD, the Recover, Restore, and Decolonize team under the Forum for Naga Reconciliation team, work consists of studying and networking with indigenous elders, and that's one big reason I'm here, associating and learning from our indigenous elders here. And we also conduct participatory action research. We also generate public awareness. We have had lots of dialogues and also lectures. We develop and this is to develop a strong, viable case to make an official claim to the University of Oxford for returning the Naga human remains. So this was in Mokokchung, and then this was in Mon. This was taken last year. This is part of our team. And these are our elders in Longwa village, our research team. Yeah, our recent visit to Melbourne in September at the University of Melbourne. This is what we work with. The journey begins with the realization of our realities today. And this is stated by one of our own anthropologists, Dr. Dolly Kikon. So our learning is an ongoing process. There are three things I want to point out. Three things we are finding ourselves emerging in, and one is the confronting the past. Confronting the past. Nagas are people who are enduring decades of colonization, oppression, and subjugation of various forms. Our indigenous knowledge, what we know of our culture and practices, are passed down orally from one generation to another. What we know of the past is that Nagas followed well-respected and sacred cultural and spiritual practices. So the knowledge that our ancestral human remains are housed somewhere else or boxed up somewhere evokes strong emotions in us, mixed feelings, and we have to confront our fragmented history. Secondly, we have to pursue healing path. The most poignant words uttered by Dr. Gary Deverell, an Australian Indigenous pastor, teacher, and author, resonates with us. What he said, quote, "We are colonized people. Either we lament and be creative in the space, working with good traditions and weave new clothes that clothe us and warm us." That makes so much sense. We use a lot of hand-woven clothes in our culture. Return involves disruption and is not possible to return to the same. Returning requires a commitment to reality and involves repairing work. There is also the tension of what we know and what we don't know. We are challenged to critically look into our belief systems, our culture, both past and present, and our understanding of our spirituality. We cannot ignore the past. The past beckons us to look critically to our present circumstances and our experiences. And finally, we have to address intergenerational trauma. Communities such as the Nagas, like ours, are prone to face many mental health issues due to the still ongoing geopolitical conflicts. It is a community riddled with uncertainties and ambiguities. Our internalized trauma of the past needs to be explored and addressed. We have become victims of other people's decisions or subjected to other powers, and also complexities within ourselves. In that, we have become overly dependent and powerless, affecting our mental health. There are issues of shame, guilt, fear, anger, and mistrust that we need to address. We need to acknowledge and address the traumas of the past. Then only can we understand our present realities and create a better future. Thank you for this time, and thank you for listening.
Thank you so much. Questions, comments? I won't embarrass you by asking how many people knew where Nagaland was located. What does it mean to have an international boundary run through the middle of a village? How does that work?
Yeah, yes, it shocks everyone who hears about it. So what happened is in the past when the British, and sir, you're from the UK, right? Not you, but in the past. Apparently, what happens is that administrators from a distant place, they kind of, demarcated the boundaries without seeing the realities, and I think that's the result of what happened. So it's in Longwa, and it is very famous. We have thousands of visitors come every year. So the Ang house, Ang is the chief of the village. He has his huge home, and the boundary runs right through that house. And I should have brought some pictures of that place. I mean, and you're welcome to come and see for yourself.
There's nothing I can say here, but the British do not have a very good history of drawing partitions. Think about India, Pakistan, think about Sykes-Picot in the Middle East. I didn't know about Myanmar, India, but by golly. And I think it actually is symbolic of something very important. I know that when I first went to Arnhem Land in the Northern Territory of Australia, and the first thing that Indigenous people there said to me in a remote community is, why on earth would you think people in Canberra have any conception of what our lives are like? So your point, I think, is a general one, that colonialists don't actually understand what on earth they're doing.
So we do have identity crisis. And we're talking about healthcare system, you saw some of the pictures. They have no access to healthcare. We don't have hospitals, proper hospitals. I was just wishing we have mobile clinics at least, looking at some of the presentations yesterday and today. But yes, we have a lot of crises, identity crisis, land disputes, and lots of fighting between communities. Yeah.
Other questions or comments? Thank you very much. So finally, Shita, Dewi, and Harvy Joy Liwanag are going to talk about co-creation for strengthening health policy and systems research in Asia. And Harvy is in Bern. He looks like a typical Swiss citizen. But before that, it was the Philippines. And Shita, where are you now? Indonesia. In Indonesia. Center for Health Policy and Management in Indonesia, please.
Hello, everybody. Can you hear me right? Okay. So thank you, Sir Michael, and good afternoon, everyone. So Shita and I are delighted to have this opportunity to share about our initiative to strengthen health policy and systems research in Asia through co-creation. So aligned with the theme of our World Health Summit in this meeting to shape the future of health in Asia Pacific, in this presentation we will focus on, number one, the field that is called health policy and systems research, what is otherwise known as HPSR, and number two, this notion of co-creation, which may be called by other terms such as participation, engagement, collaboration, partnership, co-design, I would say. But I think in today's presentation, we will not get into a semantic analysis of their nuances, but just to say that I think we kind of know what these terms mean. So let me begin by HPSR. Anybody here who consider themselves as health policy and systems researchers? Raise your hand. Perfect. We have Sir, one, I think, and three. So we have three here in this room. I think we need to involve more health policy and systems researchers in the World Health Summit. So let's review a little bit and refer to the official definition provided by the Alliance for Health Policy and Systems Research, which is hosted by the WHO in Geneva. So the field The types of questions that HPSR explores have to do with analyzing health systems and the interactions of the components and actors within the health system, and how these all together contribute to achieving collective health goals, including questions that explore the links between health systems and policy and implementation. And so because the field of HPSR is defined more by the questions it seeks to address rather than by its methods, it is inevitably interdisciplinary by nature, deploying a wide range of methodologies to produce results that contribute to policy outcomes. So that's HPSR. Now let's touch a bit on co-creation. And sorry if I'm speaking quickly because we only have 10 minutes. Let me illustrate this by referring to this paper that described the work that we did as researchers working closely, or maybe I would say researchers co-creating with policymakers in the Philippine Department of Health and other stakeholders to develop the strategic plan for the health workforce in the Philippines. And you can check out the article by scanning the QR code right there. So when we think about evidence to policy translation, the conventional and usual approach is a linear model where on one side you have researchers who do the research and then who will then pass on the knowledge to policymakers who are on the other side hoping that the knowledge is utilized for policy and practice. In contrast, the co-creation model moves away from this linear process and endeavors to bring researchers, policymakers, and other stakeholders together in the entirety of the process from the time the problems are identified, the research questions are conceptualized, the methods developed and implemented, the data collected and analyzed, and the evidence used for policy, bringing knowledge co-production and collaborative action as part of the same cycle. Now, when referring to co-creation, or perhaps participation more broadly, we have to be aware as well that not all types of participation are equal. So if, for example, if you do a round of simple consultation with stakeholders, what is the depth of participation in that process? So here, I think Arnstein's ladder of participation is a useful guide because it helps us appreciate a spectrum of participation, where towards one end of the ladder, we might be claiming to be participatory, when in fact it is only a tokenistic form of participation. And the higher level form of participation is towards the other end of the ladder, where there is in fact shared decision-making and power among stakeholders. And this is the depth of participation we seek to achieve when we practice co-creation. Now, the Health System Strengthening Accelerator is a 5-year cooperative agreement supported by USAID and facilitated by Results for Development to support health systems strengthening in low and middle income countries in Asia by engaging in-country institutions, both public and private, and at different levels, to identify health policy and systems, needs and priorities, address these needs by leveraging on regional and domestic expertise, bringing together all these institutional partners based on co-creation, drawing from perspectives and experiences across multiple geographies and contexts in the region, and generating knowledge from the process as part of adaptive learning. We don't have the time to report on everything that happened in this co-creation process, but suffice it to say that the slide is not moving. But yeah, it's not moving. Okay. Suffice it to say that one of the milestones we had, it moved, yes, thank you, to the invisible hand. One milestone we had in 2021 was a co-created vision involving different institutions in the region. And the vision was to strengthen the HPSR ecosystem in Asia, which led to the ideation of a set of pilot projects proposed and implemented by different health policy and systems research institutions, or what we now call as HIPSRIs, to contribute to the vision of shaping a robust HPSR ecosystem. Details about these pilots are available in that QR code you see there, but today we will showcase pilots from Indonesia, Nepal, and the Philippines, and it is here where I pass on to Shita.
Thank you, Harvy.
Yes, so our journey to strengthen HPSR in Asia Pacific begins with trying to understand the landscape. And here I present an example from Indonesia, but we found similarities with other LMICs across our pilot countries as well. So we have the main actors here, we have the policymakers, we have the developing partners, we have the HPSR institution or HIPSRIs, and we also have in some cases, national research agencies and policy analysts embedded in the Ministry of Health. And as in many ecosystems, there are intersection and relationship happening between these actors and in HPSR. These are really about priority setting agenda, resource flow, and hopefully also research and evidence uptake. But this is, however, is not always the case. So this ecosystem is running mostly on trust. And for HIPSRIs that are matured or traditionally based in academic institutions, the relationship is pretty much there. But for smaller HIPSRIs, those located away from the central government, usually there are lack of presence. So policymakers and developing partners sometimes may not be aware even of their existence, and so they tend to, come over and over again to the same HIPSRIs or to the same people asking this different kind of questions. And at the same time, HPSR is very complex. It requires interdisciplinary expertise and combined methods from multiple disciplines, as Harvy has mentioned before. So it is crucial for HIPSRIs to be able to collaborate among themselves. But in most cases, we do not even know who else is there in our country doing HPSR. So our pilot was to develop a database of HIPSRI. We started small, only including Indonesia, the Philippines, and India, identifying who's who and who's been doing what. And so in time, we hope to have a repository of knowledge, if you will, and some kind of directory of expertise, if you will. We also identify which area of focus of HPSR that are still lacking and which area that already quite established. And we want to identify what needs to be there for us HIPSRIs to be able to be working together for impact. So how to unlock this potential for collaboration. This is such a small start, we understand, but we hope that this database could potentially support policymakers and developing partners as well to identify more local partners to foster locally led solution and a more efficient and investment in research by avoiding redundancy. And our co-creation work also uncovers some challenges that HPSR encountered. Here we present an example from the Nepal context. So we understand how there are still hurdles at all levels that impede the growth of HPSR as an area of expertise, particularly lack of investment in capacity, not only at individual level, but mostly on organization level and system level. And HIPSRIs varies, of course, in terms of available resources available to them to address these challenges in some level more than the other. To help HIPSRI build the capacity to play its role effectively in the HPSR ecosystem, co-creation work in the Philippines developed a framework to analyze organizational capacity to be able to address the capacity building need and to systematically address them. This framework was also developed also in collaboration with the policymakers as the user of HIPSRIs, of course. And we found that the framework identifies 4 domains and 8 key attributes for to make a HIPSRI robust. And this includes the technical capacity, and by technical capacity, we also include not individual capacity, but organizational capacity. We also highlight the importance of effective leadership, managerial capacity, skills, and capacity to engage and build relationship and to network, very important, and also to do knowledge translation and being policy responsive. Limited capacity in any of these domains will become a barrier to efficiently and effectively tackling emerging health challenges in Asia Pacific using a system and policy approach. So I think our key messages reiterate the common theme of trust and co-development that we heard yesterday and also a local solution that we heard today. It is important for HIPSRI to remember that we are not in the business of only generating evidence or doing evidence synthesis. We are here to make an impact. We are here to make a change. So it is important that co-creation needs to happen between a range of actors in the ecosystem. We start as HIP3, engaging the policymakers, but we also need to think about a wider range of stakeholders. We want to also involve professional organizations, media, and ultimately the communities. And we would also like to see a step up in capacity building investment towards institutional capacity, including the capacity of the policymakers themselves to function as a steward, if you will, for HPSR to be able to shape the future of the health in Asia Pacific. So thank you, and we thank our partners who are not able to join us today, but they are part of the co-creation process across the region. And thank you also for our generous donors, especially the USA. Thank you.
Thank you very much. Seems my role to ask the first question. You started with a description, more than a definition, of health systems and policy research. My concern, and the question I want to ask you, is that although it includes social determinants of health, in practice, it's really about healthcare systems. Or can you expand it to include social determinants of health?
Thank you, Sir Michael, for the question. Oh, should I stand up? No?
Yeah.
Oh, I should. Sorry. Yes, thank you, Sir Michael. Yes, I think one of the challenges that HPSR is also tackling is we want to also reach the cross-sectoral, multi-sectoral approach. So we are not only looking at the health system per se. We understand that health system sits within a wider system, if you will. So they are very much influenced by other sectors. So here we also, of course, taken into consideration not the social determinants of health, but nowadays, even the not only the social determinants of health, but also the, what is it called? The market determinants of health? Commercial determinants of health. So looking into the way that we converse ideas, policy agenda with other sectors is very, very important in the HPSR. We understand that a lot of the work that the health sector is doing is probably being influenced by other sectors, by policy in other sectors. Yeah, thank you.
Thank you. Other questions or comments? Well, thank you. Superficially, you might have said that we had some very different presentations this afternoon, dealing with wildfires, and dealing with guidelines and their impact, liver flukes, and the legacy of British colonialism. And now we're talking about health systems. What linked all of them was the importance of community. You talk about co-creation. I recently was trying to figure out, I was reviewing for The Lancet a book that declared itself a liberal approach to public health. And I was trying to understand, this word liberal gets thrown around a lot. What is it about? And among the many things I came across in talking about a liberal approach was that liberals, and I'm not declaring myself as a liberal, I'm just telling you what I've found out, would say that trying to get people to do things that some institution wants them to do is wrong on two grounds. The first is, for followers of Immanuel Kant, for the philosopher, it's treating people as means rather than ends. So if you want, you from the outside are trying to push people in a certain direction, you're not treating them as dignified individuals. You're treating them as means, not ends. And a second objection is a welfarist one. If you're pushing people in a certain direction, the evidence suggests it may not be in their interest to do it. It may be in somebody else's interest. And that's really quite interesting. Without declaring yourself a liberal or a non-liberal or something else, what we're hearing with the whole principle of co-creation, community involvement, lived experience, however we want to describe it, is people being involved in the decision-making process, both from a philosophical point of view, it has to be right, people not being treated as means, but having dignified lives, which they control. And from a welfare perspective, it's likely to lead to better outcomes if people are involved. So I think the way you finished is actually a good theme for the whole afternoon. Co-creation is absolutely fundamental for these two reasons. So I want to say thank you for our series of apparently different presentations for being variations on that theme. Thank you.